Hello, everyone. I'm Azhar Hirani. Welcome to another episode of Practice Unlocked. I have a very special guest here, Dr. Shalaby, who is a board-certified cardiologist and an author of 6 books related to heart health. And along with that, he has done extensive work on early detection of cardiac disease and is a creator of many preventative programs on the cardiac side of things. So welcome, Dr. Shalaby. Thank you for coming on the episode.
Thank you very much. Appreciate being with you here, and looking forward to discuss with you.
Fantastic. Well, I did not give you justice in the in the introduction, so please tell us about yourself. Who is Dr. Shalaby? Your background, your schooling, and then also the amazing accomplishments that you've had so far.
I came from Egypt, Cairo, Egypt. That's where I was born. I grew up there. I went to medical school in the Cairo University School of Medicine. Mm-hmm. And this is one of the oldest or probably the oldest medical school in the Middle East. After finishing medical school, I came directly to the United States to continue my training. I started by doing research in University of Boston. I have a very good time in Boston, a lovely town. Mm-hmm. Then started my medicine training in the University of Missouri, Columbia. Mm-hmm. And then moved to New Orleans, Louisiana, on the Marshall Clinic Foundation for my cardiology training. So this was my training years. Then very fruitful years, wonderful mentors and staff that kind of helped us every step along the way. Then I started my practice as a cardiologist. Moved a few years before coming to Houston. Practiced in Illinois and in Ohio, then ended up here in Houston in 2007, and I've been here for a while. It looks like I love Texas, so Texas loved me as well, so kind of grew up our kids here, and it has been a very, very satisfying experience so far.
Amazing. So all the places that you mentioned was mostly for training, and then did you work in the hospital practice before you started your private practice? Did you go straight into private practice, or?
Yeah. So when I graduated from my fellowship, that was back in 2003. So I joined a group cardiology practice. I have 14 cardiologists group. That was in Illinois, very close to St. Louis, and that was my introduction to cardiology. It was a very good experience. Now. And that's kind of where I got exposed to private practice, learned a lot from the senior physicians who were in the group, who have been in practice for like 20, 30 years, some of them. The practice also have an amazing management team, and from them I learned a lot also about cardiology. So this was my introduction. It was a big group, so that also comes with a lot of what do you want to call it? The bureaucracy. The bureaucracy. So it was a well-structured group. So besides medicine, you get exposed to what is politics, what in medicine now in the medical environment, what is being a good customer service to your referring doctors and for your patients, and the relationship with the hospitals and all that. So it was a very good experience for a fresh fellow just coming out of training. So it was great.
I can imagine you need to go through that in order to know what you need to adapt in your new practice, and also the things that you need to eliminate in your new practice as well.
100%.
Yes. And then I know being an international, you studied medicine in Cairo?
Yes.
And coming here, when you come here, do you have to do further education, or you go straight into residency?
So you don't have to do any further education. You do the SMLA, which is still until today, and that's for both, for American graduates and for foreign medical grads. Both of them goes through USMLA, and you apply for residency, and once you start your training, you just kind of your own. So no, So for medical graduates, FMGs is a kind of an abbreviation. You don't need any additional education. You just need your SMLE, your spot in training, and you're on after that.
I see. And then in terms of like cardiology in itself, did you always knew? When did you kind of find out that, okay, that's what I want to pursue? Because usually you do, internal med.
That's right.
Or and then that's when you do your rotations and things like that. Is that when you started thinking like, okay, cardiology is something that I'm interested in, or you've always been passionate about cardiology? Even prior to that. Yeah.
No, I wasn't decided when I started my internal medicine residency, which in my opinion, the greatest training that you can get exposed to is internal medicine, and that's biased, but you get exposed to a lot of things. So you get exposed to around 25 subspecialties that you can be part of, and it has a wide variety of dealing with very critically ill patients, dealing with patients who are stable, dealing with patient outpatient setup. So during these rotations in the first couple of years, I kind of find that cardiology was the most satisfying in terms of the combination of the clinical skills, the science base, the research base. Also that time, and still, cardiology have been rapidly progressive on all fronts. I mean, it took, between the mid-70s and now, cardiology have changed completely the way it has been practiced, understood, and delivered to the patient.
Amazing. So are you an interventional cardiologist or a non-interventional?
Yeah, I'm a non-interventional cardiologist. So that means cardiology is, besides that being a very interesting, but it's a very broad subspecialty. So meaning that the amount of science, the amount of areas that we need to cover is big. So we have 9 subspecialties inside the subspecialty of cardiology. All that used to be right before the time I started cardiology training, which was in 2000, was only cardiology. So you just do your training, it was 2 years initially, then became 3 years. Then you can choose to do whatever you wanted to do. You want to do intervention, that's fine. You want to do clinical, which I choose to do. Then with time, the amount of science and technology and the skills needed for them evolved. So it became your interventionalist, your electrophysiologist, then came other some stress like imaging and preventive cardiology and geriatric cardiology and things like that.
I haven't heard of any of these, by the way.
Yeah.
I've heard of like 1 or 2.
Yeah.
I did not know that. Okay.
Yeah, then there's heart failure. So there is multiple subspecialties that you have to train for and sit for board for to practice.
Oh, I see. I'm assuming a lot of these don't actually even do private practice, right? A lot of them probably are in the hospital or...
They're more appropriate for a hospital.
Okay.
Meaning that they can if they choose to, but like the heart failure, heart transplant, these are very structured program that needs a multidisciplinary team to work on. So that's always sponsored. You see it in Methodist and St. Luke's in the big medical centers. Imaging also, I don't think in a private practice, unless you work within a huge group, that you can kind of financially survive just by doing imaging, unless again you work in a big medical center.
Crazy. Yeah. So, picking off the topic of finance and surviving.
Yes.
So obviously everyone knows, okay, interventional cardiologists, the way they monetize their practice, and obviously you need to survive as a physician because you have to pay the staff and keep the lights running and things like that. So patient comes in, you monitor them, and then once they need intervention, the doctor intervenes. There's dollars to be made in that. So but a non-interventional cardiologist, how do they monetize their practice usually?
Very good. So here's the good news. Now, and that's for everybody who is thinking about cardiology, or every fellow who's doing cardiology, or every medical student who are thinking it. Now, in reality, there is no much difference between what subspecialty in cardiology do. Like everybody makes around 10% of what the others do. If you're interventionist, and in reality also, the majority of us, except in very specific situations, as we talked in the big medical centers, do the same. 90% of the time taking care of people, sitting down, listening to patients, adjusting their medications, making sure that they're healthy. That's what everybody's doing. And everybody should be proud of doing.
That's what medicine is, yeah.
That's what medicine is.
Yeah.
Then there are the niche that everybody chooses, everybody enjoys doing. So intervention is hard work, is a lot of skills, is a lot of risk taken on the. So I 100% credit them for a lot of the development they have, especially in acute cases. But I would say if you are thinking of what subspecialty in cardiology makes more money, I would say this is not the way to think about it. I would think, what do I enjoy doing the most, and where can I offer most value? Because at the end, almost everybody makes the same.
Makes sense.
Yeah, and that's after you go and study the data from all the kind of the surveys, you'll find everybody's making around 10%
Of each other.
Of each other, yeah. So it comes down to how long you've been in practice, what setup of practice you are in, and how good you are with your patients, and kind of all that, yeah.
I know you're very passionate about the prevention aspect of things.
Yeah.
And very few practices actually, like every physician I know a lot about prevention.
Yeah.
But I know at the other side, they need to see 30, 35, 40 patients a day in order to survive in their clinic. So spending a lot of time on prevention doesn't necessarily get them the reimbursement from the, because majority of the times there is few dollars in the reimbursement parts. Now insurance companies are getting smarter, governmental programs are getting smarter that, hey, through prevention, physicians can do better, which is fantastic. And now the technology's also coming along as well to track it, because I know they tried it in the 80s and 90s.
Yeah.
Because there were no EMRs, it was hard to track it. Now, how can someone monetize prevention as well? And also go into a little bit about your theory about, hey, because you always say, it's all about you take care of patients, you do a good job, they get better, and as a physician, that's what you're made to do, and that's satisfaction, and money will come somehow, through.
Right. So here's the thing. Now, physicians, since this career was invented at the dawn of humanity, we were there before anybody else, before armies, before governments, before anything. Now, humanity recognized that when a human being is in pain, someone needs to take care of them.
Yeah.
And if this someone have the knowledge, then he deserves the respect of the people. So this is a physician. This is our career. So if you are in medicine to become rich, especially rich fast, maybe this is not the right career for you.
That's why I didn't choose it, by the way. No, kidding.
If you want that, maybe you want to talk to Azhar. So he will tell you how. But if you are in medicine to make a very decent life, serve people and interact with people, and make a difference in life, relieve a lot of suffering, keep people healthy, then you will be rewarded beyond what you imagine.
Amazing. So, do your methods of prevention, do your colleagues agree as well? Do they understand it, or do you have a difficult time addressing that? Because I know in medical school, they talk about prevention, but really the nitty-gritty of how you could do certain things to prevent certain diseases is not thoroughly discussed. There are other programs they can go into to study deep into it, but or through peer-reviewed papers and things like that.
Yeah.
But when you talk to your colleagues, do they agree, disagree, or?
Very good. So here's the thing. Now, almost all the physicians I know, my colleagues, the people I practice with, are very good doctors, and they, for the most part, I mean, they do what is right for the patients. They in heart, they are quality people who wants to do what's best for their patients. Now, and the system is what gears physicians to practice certain way or the other, right? So medicine is, and you probably know that because you're on the business side of medicine, is 30% of the GDP. That's a lot of money.
A lot.
So when you have this amount of money, then comes the people who make the majority of this money want to gear it in one way or the other. So if I make it really difficult for you as a physician to sit with your patient, talk to them, figure out what's going on, and discuss a little bit about how can we improve the situation, and I kind of remove any financial incentive of doing that and put all the money on taking those patients to do procedures and put stents and kind of procedure, then I am not helping you to do what is right for the patient, what's right from the scientific and research standpoint. So back to science. So everything I do and everything the majority of doctors do, that whether we call it prevention, we call it clinical medicine, have proven to be the most effective way to treat patients. So everything else is either culture-based, meaning that we build the culture, that including the patients, by the way.
Yeah.
That the patient, you're going to go and see a cardiologist, and you would have a stent, and you'd be good.
Yeah.
Right? So with the science that studied stenting for stable patients for the last 40 since stenting came around, did not show that.
Yeah.
It showed that you would do as good as the patient who kind of followed the diet, exercised regularly, modified their stress factors, took their medications if they have a medical condition like diabetes or hypertension, took their medication, and followed up with the physician. These did as good as the people who have open heart surgery and stenting 1 or 2 or 3, except certain situations when someone is really sick, acutely sick, in the ER having a heart attack. That's where the stent becomes kind of a lifesaver, and that's what needs to be done.
Amazing. So can you unpack that for me? So you said, like prevention, and how you can really control the situation through diet, exercise.
Yes.
But diet's obviously very important. So can you go into your preventative programs that you've designed?
Yes.
Go a little deeper into that?
Very good. So now at first we kind of, when patients come and they come with different complaints. So they come to a cardiologist for a multitude that really can translate into heart disease. So chest pain, shortness of breath, I'm tired, I'm dizzy, I cannot exercise as before, right? I passed out. Then the first thing in our business is to sit and kind of dissect the story and make something out of it. Then we say, let's do some objective data work to see where was on. Let's check your cholesterol, let's check your blood work, let's do an echocardiogram, that's an ultrasound. It's a very simple study. If we're very suspicious about a blockage in the heart, we do what we call a stress test, right? Which is a treadmill or a camera this test. So that will give us, we'll put you on one of 3 categories: low risk, intermediate risk, and high risk. And for those, we kind of tailor a program for you. So we'll say that we want you on this diet, we want you on this type of exercise. Now we follow the American Heart Association. Their recommendation is to exercise 150 minutes cardio exercise, 150 minutes a week, and we put you also on a stress management program, and we make sure that you sleep good. So we always tell that to our patient. There are 3 pillars for your health: eat, move, and sleep.
Amazing.
If you do these three things good, you're not going to need my services, not for long. So based on that, so if you're low risk, but you're kind of overweight, you're not eating good, you're kind of have some risk factors, that usually is enough. Enough to take care of most of the hypertension, most of the high cholesterol, most of the symptom that's resulting from your lifestyle and all of that. If you're intermediate risk, meaning you're someone who is, their cholesterol is high, out of proportion to what you eat. So meaning that you're genetically inherited a gene that does not make your cholesterol come down. And we see the risk coming. If you're diabetic, that makes you at the higher category. So if you've come of family with heart disease, then here we say, lifestyle is yes, that's a base for everything, but we want you also to be on certain medications that we're going to follow, and we put in targets for your cholesterol, targets for your blood sugar, targets for your body weight. So we upgrade the program based on your risk, and then we have the high risk population, and those are people who have the risk factors, like if you're diabetic, if you're a smoker, and if you're obese, and if you came from a family of heart disease, and you're not responding to medical therapy, that's when we say, okay, so it looks like you have a blockage, and this blockage, you're not responding to medical therapy, then you'll be most helped by what we call revascularization, opening up blood flow, and that's done by stents, most cases, or by open heart surgery. Still, a lot of people are the anatomy of their coronary and the kind of blockage they have, the location of the blockage or the number would not make them a good candidate for a stent, then they go to open heart surgery.
Got it.
Yeah.
Amazing. So, if other physicians or other cardiologists want to get more information on it or learn more about it, are there certain programs they can go into after they finish medical school and they're already in practice?
Oh, there is a fellowship for preventive everything. So cardiology, I have a fellowship in preventive cardiology. I think after you finish your family practice, you can do the same. Now, most of the primary care medicine training programs put a huge emphasis on prevention. So family practice, internal medicine. So you get very well trained. If you are into it and you want to delve into it, then you look for a preventive health program that based on the subspecialty that you're in, and that will give you more in-depth that. And again, those are good for knowledge. Now, if you are a private practice doctor and you're done with your training and you don't look at yourself as being a professor in somewhere, you can do good with your general cardiology. You get trained very good in preventive cardiology, and you can do that by attending meetings and staying up on your reading and kind of seeing what's happening in the market. If you want to pursue an academic career, then it would be very good to do a fellowship in preventive cardiology.
Amazing. So, I want to actually tell you a story.
Yes.
So I truly believe in this because it's happened in my family's life.
Yeah.
My father was diagnosed with diabetes and heart disease in 2018. And I vividly remember it because we were on a trip traveling, so we were all together. He gets a phone call saying, hey, your blood work and everything came back not so good. All the tests that we ran, he was an internal medicine doctor that diagnosed that. He says, hey, you have diabetes and I suspect you have heart disease. We need to, right when you come back, we need to go, visit a cardiologist right away. We cut the trip short-ish, and came back. And first thing we did is go to a cardiologist. The cardiologist said, hey, they did the stress test, they did all the tests. And then a few days later, they're like, hey, you need a few stents and a bypass possibly. Majority of your arteries around the heart is blocked.
Yeah.
And my father was like, no, he did not want to do any intervention. He was like stark believer of that. Hey, I want to see if there's any alternative therapies out there.
Yeah.
And then as a family, we were like, no, it's okay. You need to go through this, but he's like, I really don't want, I don't want that. That needs to be the last resort. So we tried to research, and upon our research, we, came across a few doctors, and this is, a few years ago, few doctors that were really talking about preventative medicine, especially through diet.
Yeah.
And, the diet was very strict. It was no meat, no dairy, and no oil.
So vegetarian diet.
Yeah, and it was completely a plant-based with no oil.
Yeah.
And plant-based we understood, but oil we didn't really understand. And so we found a doctor in the Cleveland Clinic. So we flew to Ohio, went through their training or their program, came back, and there were many testimonials of people who were reversed heart disease. What I found out is you really don't reverse heart disease. It's just you get your arteries to work a little bit better and things like that. Came back, applied that like hardcore. Everything in our household, majority of our family members started eating plant-based, no oil, no nothing, and saw a significant improvement. So he was, given a few medicines, and he's now down to like half a medicine now. So it does work. So 5 years later, it's a slow process. He found a doctor locally as well that would follow him now, and doing blood tests and things like that every quarter. And we see the improvements. So I do agree that the prevention methods do save a lot of lives. You live on a healthier level. And it decreases your stress as well of ongoing that, okay, you know that you're getting better internally day by day. But I do know that explaining this to the family, it was not only to the patient, but to the family, becomes difficult. But then to explain it to your primary care and to other doctors that you see was very difficult. So how do you handle that? Do you get calls from other doctors saying, hey, your patient's telling me this and this and this, and they won't let me do this procedure because...
Now I do most of the diagnostic work, including the angiograms. If we need an angiogram, so I do that myself. So I make the decision based on what I see and what I know about my patients. And in the environment that we're here, I didn't see people who do things out of but again, there is a culture, and this culture is not fitting with the science we have. Now, if we all the studies, and you can go and read a story like the story of your dad. If we got 1,000 patients who took the path that your dad took, and we have another 1,000 patients who either had the stents or the open heart surgery, and we followed them for the coming 10 years, which we did. We did not see any difference, actually. We did not see any difference. And the data says that heart patients in the United States is 3 times more likely to get open heart surgery compared to a heart patient in Canada. But the outcome related to death, related to the heart disease, is the same. So what happens is we just kind of spend 3 times more the same patient than when they do, and we get the same outcome. So all this, and this is not, and again, this is not a physician trying to exploit a situation. No, it is a culture that we built, and a culture we as a society, we need to rediscuss it and say, if we know from all the research we did for the 40, 50 years that is not cost efficient, let's say, is not the most cost efficient way to handle our patients, why we're not offering what we know works first and try it and see how they...
So I love that. So in terms of that, you mentioned data in the research. Where can other physicians, where can they find this research? Is there a certain...
Oh yeah, there is many clinical trials. All of them are large-size trials. All of them are adopted by the American College of Cardiology, American Heart Association. I mean, these are solid data to tell us that if you have a blockage in the heart and you're stable, that's a very important factor. You're not having chest pain all the time and you did not respond to medication, and you continue on the medical route plus lifestyle modification, you would do as good. You do as good as someone who had an open heart surgery or stents or multiple stents. Now, there is reserved cases, so people who fail to respond to medical therapy, people who are in unstable situation, don't need immediate help right away. But these studies are actually overwhelming that. If you look at the data, it's overwhelmingly towards that the medical therapy and lifestyle modification.
Amazing. So each patient that comes in, you've written 6 books, and they're all regarding prevention, heart health.
Yeah.
Do you give those to your patients and say, hey, or
Yes.
It's because when they come in, it's hard to explain it in a few minutes, and sometimes a couple hours. So how do you educate your patients? Do you tell them, hey, go watch these videos that I've made when you go home, or what's the most efficient way to explain this to your patients?
So the first book I wrote is called Heart Health Action Plan, and it goes into the multifacets of cardiology management. It goes into diet, it goes into exercise, it goes into spirituality and its relationship to heart disease. It goes into personal relationship and a relationship to heart disease. It goes into community involvement. It's like you live within a community, you live with a family, you are part of friends of a church, of a mosque, of a synagogue. I mean, you belong to someone. That makes a whole lot of difference in heart disease. It goes into entertainment and its relationship to heart disease. How much you laugh has to do with it. And there is a laugh treatment center that kind of just treats heart disease. I think that's Loma Linda. Yeah, the Loma Linda University, they studied people who belong to a laugh treatment center, and they did actually better than people who have heart surgery.
Amazing.
Yeah, and then kind of it's a prescribed structure thing, so that you go into a laughing session daily 3 or 4 times a week, and that made all the difference.
Amazing.
Yeah, so we'll start with this. We'll start by talking to them and give them the book and say, well, look at that, review it, and kind of you'll find very good ideas you might learn to. We had certified nutritionists that we work with, that we refer people. We have wellness trainers that we refer people to.
Amazing.
So kind of this network of people who believe in the same thing is how we handle most of our patients.
Amazing. So, stepping into the private practice world.
Yes.
Did you have someone you looked up to, or did you have a mentor when you got started, and how important, or what kind of role did that play in your career? And you think other younger physicians that are coming out of school, or there's certain aspiring physicians that are already in practice that want to get to the next level, what do you recommend for them as well?
Very good. So, I mean, when I started in cardiology, I trained in Azhar Clinic. It's kind of a very known southern health institutions, and it's still one of the leading healthcare systems. And over there, I had the privilege of training with people who were leaders in their kind of cardiology practice and knowledge, not only in the U.S., but kind of internationally as well. But one thing that I kind of learned from them, and I still remember, is how much they were protective of the patients and how much they kind of cared for the patients. And I remember that I was doing a procedure with one of my mentors, and I did something kind of was kind of a mistake. Then he kind of corrected that. Then I looked at him, and he was a tall guy, 6'3" guy. So, and I said, "I'm sorry." So he pointed to the patient. He said, "Say that to him. Don't tell me." So
There's no ego basically in this world. Yeah.
there isn't.
Yeah.
So I mean, so those were the kind of the group of mentors that I benefited from the most, both in the kind of the ethics and the attitude of practicing medicine, and the level of skill and knowledge. And then after that, through practice, we saw a lot of good people. I mean, kind of it's amazing. And I see, like here in Southeast Houston, I see patients who, I mean, patients now live for a long time. That's a good thing. So I see people in their 90s, but they talk to me about their cardiologist 30 and 40 years ago, and they still have all the fun memories and admiration for them.
Amazing.
The cardiologist, yeah.
No, amazing. No, I'm sure it's a very, very rewarding career. That's for sure.
It is. Yes.
So
It's hard work.
yeah,
It's very hard.
I know that. I mean, I work with numerous physicians, and one thing I got to know is it is not an easy career. It is, patients come first. That means whenever you get a call, you have to be there for your patient, regardless of the time and where you're at.
Yeah.
And it's a very demanding career. So, if someone wants to get into the medical field, let's say they're not in it yet, someone wants to get into the medical field, what kind of advice would you give them?
Very good. So, so now again, so those kind of the basics. Now, the world that we live in today, everything around us tell us that if you want to make money, there are much more rewarding, faster ways to make money. Okay, so take this away. Okay. The second is it is a long way. So if you don't enjoy it, if you're not having fun every step along the way, it will be very draining and is not going to be good for how you feel or your mental health or how you handle your family and stuff. So make sure that you enjoy that. Mm-hmm. The third is medicine is a career for people. It's like you have to like people. You have to enjoy. Oh yeah. So with the exception of some specialties that kind of they deal with images or technicalities a little bit.
We could say it out loud. Radiologist or okay.
So, yeah, I mean, I don't know if radiologists like people or not, but they deal with images. So X-rays, they include pathologists, certain areas. But so make sure that you like people. You like people because not only your patients. It's a huge communication circle around every patient. So I talk to 5-6 other subspecialties at the same time. I meet the families and the other families from California and from Chicago, and they call me to ask about the same patient. Yeah. And we meet social workers, and we meet nutritionists, and we meet what we call them the people who transfer patients from one facility, utilization review, right? Yeah. So it's a huge sort of way. So you'll be talking to people all the time, and you have to be smooth with that. Okay? You have to be easy. You have to be a team player, whether you work in a group by yourself. But the team that takes care of a patient is a big team, and it's very diverse, and you have to like that.
Yeah.
So if you have this, if you have these things, okay, you like people. You're passionate about medicine.
Yeah.
You can sustain the long path to graduate mid school. Mm-hmm. Now I have 2 kids in mid school, by the way, so I know how that's. So to graduate from mid school, and then find all your friends have already started their banking careers or career engineering or finance and started. And then you look in front of you and you see you still have 6 years or 8 years of minimum pay, long hours, very hard training. You got to be loving that to do.
Absolutely.
You got to be enjoying that, and you see the value of it.
No, I love it. So that's the fun part of medicine. Now the tough parts of how does someone deal with with the insurance companies? Because obviously, guidelines change, what they can pay, what they cannot.
Oh, sure.
Obviously, it can get frustrating at times.
Yeah.
Do you also come across that as well within your practice?
100%. So here's the thing. The hardest thing in a private practice life, which is private practice like me, I work for myself, so I run my practice, I do that, is dealing with the insurance companies.
Yeah.
Why? It's big systems, and they have a lot of rules, they have a lot of processes that you have to go through, and it gets, it eats a lot of resources. That's why you see the overhead is 50, 55%, 60%, 65%. Why? Because you need a lot of employees to understand the system and do the authorization, which before you do anything, you get the authorization of the insurance companies. So this is a tough part of it. And that's why you see, and we will see that continue to grow, that most physicians are moving from private practice to corporate practice, where they form bigger groups or join existing institutions like a university, HMO, or a private equity. Recently have been big also.
Yeah. So the point, and I know they move as well because of the practice management part. It can get very overwhelming for a solo practitioner to run their practice. So you personally, you're a solo practitioner or you have a partner?
No, I'm a solo practitioner.
Solo practitioner. So, and in terms of the practice management of things, the billing collection of things, you do everything in-house?
We outsource our billing to a national company. So we do the front part, like we do the office part of it, then they do the rest of it.
Got it.
We've been with them for 15 years, so we're doing very good.
Amazing. Do you recommend others as well go that route to do the office part yourself and then the back-end collections through a third party?
Yeah, it works out better unless you, for example, you have a very trusted employee or a family member who understand the billing.
Yeah.
Because I tried that. So you hire one or two people for billing, but so someone gets sick or a family member gets sick, then you cannot sustain a it dries your accounts.
Absolutely.
You have expenses you have to meet on a regular basis.
Yeah.
So, but when you use a company, they usually have the resources to replace employees and keep the process going.
Yeah, no, I've seen that if your spouse is not, a physician in itself, a lot of spouses do take on the back office items. Either they're the practice manager or on the collection end, because it's a very trusted source you need to have.
It is someone that you rely on. Now, there's few practices still doing their billing in-house, but the majority is outsourcing it. Yeah.
Amazing. Well, I know we're going over our time a little bit, so I have one last question for you.
Yes.
Okay. And this is the hot topic throughout the world right now.
Yes.
Which is artificial intelligence.
Yes.
AI.
Yeah.
If you can help, give us an insight. Is it affecting cardiology at the moment? And then also, is it affecting healthcare at the moment as well?
Pretty good. So now AI effect on everything in our life is like all the major things that happened in the last 150 years, okay? Like discovering electricity, like the internet, right? Like the smartphones.
Yeah.
So it would change everything after that, and including medicine. Now, I think AI would have a very positive impact on medicine as long as it is governed by good rules. As you know, we in this country, as well as most of the most of the parts of the world, suffer from shortage in healthcare workers. Right? We have definitely a crisis in nurses, and all the hospitals like that. The hospital says like full. They're not full. They don't have enough staff to run.
Okay, makes sense.
Yeah, so we need nurses, we need nurse practitioners, we need doctors, and we're not at capacity. And this as because we kind of the older population, they get sicker, the population continues to grow. So making the physician more efficient and kind of pulling the data and making scenarios, that's where artificial intelligence will save time. We gather information, especially when we create the systems that will connect the dots together, meaning that when you come to me, I will sit with you and discuss some, and then at the end of our discussion, maybe I have 100 data point I know about you, and from those I will conclude things. Well, artificial intelligence will be, by the time I see you, and if the system is interconnected with your medical history and your other doctors, I probably have 100,000 data point about you, and I have, out of those, I have scenarios that what you're coming with is probably so and so because your father had this history, your brother had a surgery, something related, and you were diagnosed with maybe measles, so something like that.
Right.
So when this comes to the physician, so we have more data, more sorted out scenarios, and what is left is the kind of the clinical touch and seeing if this applies to you or not. So this is one part.
So is it available already, or it's being developed at the moment?
Well, I mean, it has been available for 15 years. Maybe ChatGPT is what made it more popular now and brought it to the public, but it has been available and it has been evolving. Now, I'm sure the competition between the kind of all the tech giants it will accelerate this process, especially healthcare. So we have been using it. It will evolve with time, and we will see very good results.
Amazing. Amazing. Well, this, honestly, guys, I mean, this has been a very value-packed episode. So honestly, thank you, Dr. Shalaby, for coming to this podcast. I'm very, very grateful for your time.
Thank you.
And I know I have learned a lot, from this episode. And to our listeners, I know you guys have learned a lot as well. And I will see you guys next time. Thank you so much for listening. And I'll join you guys on the next episode of Practice Unlocked. Bye-bye, guys.
Bye-bye.
Thank you so much. You do.